So now I'd like to introduce our speaker. Dr. Lidia Schapira is an associate professor of medicine at Stanford University School of Medicine and director of cancer survivorship at the Stanford Comprehensive Cancer Institute. Dr. Schapira studies ways of improving communication between patients and clinicians with the ultimate goal of improving the experience of patients living with cancer and their family caregivers. She has pioneered workshops and developed innovative educational programs to improve the communication skills of cancer clinicians and build effective and compassionate teams. Dr. Schapira, welcome. It's all yours.
Thank you so much, and it's such a pleasure to be with you. Thank you for taking time to participate in this conversation. Sorry I can't see you, but I imagine that some of the things I'll say will resonate with some of you to various degrees, so I look forward to questions that will follow the presentation. The topic for us today is how to approach a difficult conversation. And what is difficult for one person may not be so difficult for somebody else. So I recognize that there's enormous diversity of experience, and hopefully some of the things that I can share with you that come both from my studying this and also from my lived experience as an oncologist for 30 years will help you perhaps strategize and think about how you can get the most. And by that I mean how you can best meet your needs to be understood, to be heard, and to feel that you have a productive relationship with your oncology clinical team. My first slide comes from a cartoon of one of my favorite artists, Kino, who's an Argentinian cartoonist. And in this cartoon, I think he gives us a beautiful depiction of how we sort of glorify some of the medical accomplishments, and perhaps we think so much about the accomplishments of the physicians and the clinicians involved that we sort of forget that medicine and surgery and the health professions are really of service, and that the patient is sitting here sort of undressed and it looks very small, and the stretcher looking at all of the reminders, the diplomas, and the honors of his surgeon in this case. And I use this cartoon a lot when I lecture doctors and clinicians, just to remind us that we need to be very humble and remember that our accomplishments mean nothing if we don't really come to these conversations and these encounters with the right attitude, and that is one of curiosity, respect, humility, and really thinking of how we can be of service to our patients. So that is the talk I give to them, and now let me give you some helpful hints of what I've learned along the way. I think it's important to think about your team and take the time, and if it's possible, the ownership of how you select the members of your team. Sometimes you may find that everybody is working together, and sometimes assembling a team requires a little bit more effort or a lot more effort. You may find that, for instance, you have a great supporter or mental health therapist that is outside of where your clinical team works, or that you find your spiritual support or your own ways of coping that in a way that is not necessarily aligned with those who are prescribing the medical treatment. So it may require time to think about who you need to support you. No one is prepared really for a diagnosis of a life-threatening illness, and this can be a very unsettling time. So taking time to think about, in the setting of this diagnosis, or perhaps if there's been an evolution in the course of the illness and there's some decisions that need to be made or changes, think about who's there to support you, and think about building a supportive team. A patient of mine once told me that in her experience living with metastatic breast cancer felt like a roller coaster ride, but she immediately said that what she felt is that she needed to set up the pillars that keep that roller coaster from crashing. And she started to name the different people who really formed those pillars. And I I was very happy to see that she thought of her clinical team as one of them, but I also recognized that we were just one. So building a supportive team means thinking about who's going to provide medical advice, who's going to be in charge of treatment, who's going to be there on the home front to keep all of the important pieces together, who's going to be there to provide emotional support or spiritual support. And as I said earlier, it may take some looking around and putting together people who may not necessarily be working together as a team. So in the process, I have here as my last bullet this concept that as you are putting together your team, I think it's really important also to think about who in your informal network of caregivers, of friends, of family, who do you really trust to give you advice? Who have you gone to at other times in your life when you've needed advice, maybe about who to marry or who to take a trip with, or where to send your kids to school, or how to deal with a coworker or colleague or a boss, who is problematic. So this is important. These are the people that you turn to. So enlist them, get their help in helping you put together a good team to manage the illness. And then it's important also to think about how you prepare to meet the clinicians, and in this case, I'm thinking about this from the point of view of the oncologist. I worked for many years at an institution, Mass General Hospital in Boston, where we met new patients as a team. There was a surgeon, a radiation oncologist, a medical oncologist, often a social worker, a genetic counselor. So it was very important for us to be prepared to meet the patients. And when I think about what made some of those consultations successful from the patient's point of view, it was that they came prepared as well. And they had an idea of what was going to be asked and what needed to be reviewed. When you're meeting an oncologist or surgeon, radiation oncologist for the first time, they will really need to review your prior records. So if you have had biopsies or imaging studies like CAT scans or MRIs or PET scans done at a different institution, it's important to set all of this up in advance so that the slides can be reviewed, the images can be reviewed, and that will minimize your frustration and the frustration on the part of the clinicians. So it's important to obtain the records, the biopsy slides, to make sure that they have been received and they have been reviewed. It's also important to learn about who is going to be there in the oncologist's office or the cancer center, who's going to serve as a link with you, who's going to guide you through, or as we now say, sort of navigate you through this maze of appointments, who's there to answer your questions so you can be as prepared as you possibly can be. In some practices and some cancer centers, there are people whose role it is really to help you, the patient and the family members, to get to appointments on time. They're often called patient navigators. They sometimes help and can be very useful answering questions. They sort of know who to go to in terms of getting all your materials looked at, where to go, where to get more support. There may be actually a resource room or a patient library. Asking about what materials are available for patients may be helpful. There may actually be a social worker or financial counselor that you may want to also meet and talk to, just in case you have questions, or perhaps just so you know and you have a contact should something arise in the future, then you already have your team assembled and aligned. I always also think it's important for this to arrive early. This is not very different from taking a flight. You need to show up at the gate, not just at the very last minute so you're out of breath, but observe early, try to arrive early and observe how the place actually works, and watch the interactions of the staff with other patients and families, and that might give you a little bit of a clue as to how the place actually works. It's important to understand the ground rules, and frankly, they may be different from one setting to another. Some places really value patients arriving on time, and they really strive to be on time for you. And others, other settings, you'll find that you really waste a lot of time. And it doesn't matter how hard you try and how early you arrive. It's somehow you're always picking up delays, whether it's waiting for a lab or waiting for the doctor or the nurse practitioner. So try to figure out how that works and see if it matches your own expectations and how you work in general. I think respect is really one of the most important things. Some places may function in a way that perhaps is a little bit more, appears more disorderly than what you like, but if you feel respected and known, and if you feel that they really are following protocols as best they can, you may be more forgiving. It's just possible that in very busy practices, if there are very sick patients, that sometimes all the schedules and all the best efforts to be on time really fall by the wayside. I think transparency is also important. You may really need to know or want to know. I certainly am the kind of person who likes to know what the rules are. So asking about it and observing it is important. Cost may be an important determinant of where you're going to decide to get your care. There may be a facility that you like very much, or where there's perhaps a lot of expertise and lots of resources, but if they're not covered by your health plan and the co-pays or transportation or the amount you're responsible for is excessive, that may not be something that is within your reach. It's important to find out what resources are available. I've been in many situations where patients and families have said, oh, I didn't know your center offered this or that, many months into our journey together. So it's important at the beginning, I think, or periodically, just to see what's available in terms of resources for support, for information, for other services. And then this issue of flexibility, I think, matters more to some than to others. How much wiggle room really is there in terms of scheduling appointments or having access to members of your professional team. You may see somebody who's really an expert and you love him or her, but they may only be available one day a week, and that may not match your schedule. So all of these things are important to figure out how you're going to position yourself, where you're going to go, and then once hopefully you have a team, you can commit, you need to trust your team to deliver for you, and setting up the proper expectations and understanding the ground rules may really help you to do that. It's important to have a good and satisfying partnership. This cartoon shows the doctor serving the patient a glass of wine. As he's sitting on the stretcher, they both look very relaxed and happy, and the doctor says, hey, my approach is not traditional, but from a uniquely Western perspective. So you may find somebody that you're comfortable with. Your perspectives may not be exactly the same. You may come from different backgrounds, but there needs to be this idea that you are in this together, that your goals are aligned, that there's a common purpose, and you need to some degree at least enjoy each other's presence and company. Setting expectations is something that needs to be done from the point of view of the physician, the office manager, but also from your point of view, from the point of view of the patient and the family or informal caregivers. One of the ways I have of explaining this in general is that even the most respectful, disciplined doctors are not mind readers. So it's important for you as the patient or the advisor to the patient to really participate in conversations and, again, ask some of the very basic questions. If I call, who's going to return my phone call and when? Do I need to call every hour? Is there some mechanism here? Do the calls end up at a call center 300 miles away? Could I have the cell phone of your nurse coordinator? How do I reach you? Who covers weekends? Who would be available if, say, you have chemotherapy one day and you feel terrible at night? Who do you call? Who will answer? Will they know you? Will they have access to your record? Who else is on this oncologist professional team? Is there a nurse practitioner, a nurse coordinator? Are there, if it's a training institution, are there fellows? That typically means oncologists in training who are available, or junior doctors. Who's going to be there for you? And then think about what's important to you and your family so that you're sure that you're in the right place and the means of communication are open. And it's important to establish that clearly. I mean, are you the kind of person, or is your oncologist the kind of person who will only have in-person conversations, or do they accept emails? Is there a place for you to submit questions ahead of your visit so they can prepare? Will they allow you to record the visit? You should always ask if that's okay, and you should be prepared to hear them say that it's not. Most oncologists I know are okay with having their visits recorded, but there are institutions where there are policies that get in the way or do not encourage this. There may be new technologies, such as the smartphone, that can actually bring in even somebody who's not in the room to be there. I remember having a consultation with a patient whose husband was working in China, and so we timed it so that he could call in, and we put the phone on speaker, and in that way he felt that he was present, he was able to ask questions, and both he and his wife, who was my patient, felt that we actually worked together as a team. But that requires a little bit of planning, and again, it needs to be negotiated. And I'm always reminded that often things happen at the worst possible times or when it's least expected. So do take the time to ask about coverage after the clinic or the office is closed, and what happens on Christmas Eve and what happens on weekends, who will be there to give you advice. Remember, you're an expert in your life and your worldview, and what you need is an oncologist who's an expert in the treatment of your disease. And then from that respectful platform, you start to build your relationship and your partnership. Don't hesitate to ask questions. The more questions asked, the more information that is exchanged. And don't worry that your questions are either silly or outside the scope. Ask and say what's on your mind, and I think the relationship will be stronger for that. It's hard sometimes to understand exactly what's being said. The medical jargon and the technical language used is often unclear, and I'm always humored by the observation that the more junior the doctors, the more medical jargon they use. But it's hard for them sometimes to remember that some of the words that we frequently use and we speak and we use to communicate among ourselves are often misunderstood. So it's important for those of us who are on the medical education side to remind clinicians all the time, but don't hesitate to say, I didn't understand, or can you please tell me what you mean by that word or that expression. Doctors often use numbers, they often use percentages, they often talk about statistics and probabilities. If you understand that, or if you master that, that's terrific. But if you didn't and you just need language to say, look, the risk is high or low, or to help you understand, go ahead and do that. And many words actually may take on a different meaning for patient and for doctor or nurse or healthcare professional. We often, as oncologists, are very reluctant to use the word cure because we think that we need to wait many years often until we can actually get an idea if somebody is cured, which means cancer gone forever, or we're sort of in that waiting period where the cancer has been treated, there's no sign of it, but we just sort of don't know, and we often use the word remission in that case instead of cure. And for us, these differences are important, and for some patients, they actually blend. Word treat, the word risk, the word cure, the word remission, all these are very meaningful, and if they're being used and you're either not completely sure of why they're used instead of another word, what they mean, be sure to ask. So I just want to take a moment here to do this little exercise with you and show you also that a lot of what's said in the communication can be framed very positively or negatively, and perhaps how it's framed also impacts on how you experience what that information means, or how it sets you up to then cope with it. So in the panel on the left-hand side, you see this 100 dot diagram with 2 in red. So a doctor might say, look, a study shows that, let me start by saying you have 2 in 100 chances that you will have, say, a heart attack if you don't take aspirin. And so Dr. A might look at this and say, a study shows that aspirin will reduce your risk of a heart attack by 1% from 2%. So on the left side, you see 2 red dots. On the right, you see 1. So that means that by doing treatment A, in this case taking an aspirin or eating a jelly bean or taking chemotherapy, you reduce your risk from 2%, those 2 red dots, to 1. And so it's a very small risk, right? And by doing the treatment, you're reducing it, significantly. You're cutting it in half. But it was a small risk to begin with, and you're now making it smaller. So you can use some caution when you explain the benefit of the treatment, or you can come in the room full of enthusiasm and say, hey, I have a treatment that will cut in half your risk of having a heart attack. And it's true, you've gone from 2% to 1%. But in that second case, a lot of the sort of the upbeat presentation may hide the fact that the benefit is relatively small. So I hope this exercise didn't confuse, but it just shows you that so much depends on framing, presentation, and tone that you need to be careful before perhaps accepting to take a treatment, or if there's several choices, that you really understand what's being explained in terms of what you can expect as your possible benefit from a treatment. And even when things are said very clearly, we know from many good level studies that often patients and doctors don't remember the same thing, and often patients don't remember a lot of what was said. And we know that because this has been done and studied by taping the actual consultations, and then when you ask people what they remember and you go back and you hear what was actually said, you realize that there's often a mismatch. So taking somebody with you to the consultation may help, so that somebody else is there, another pair of ears, somebody taking notes perhaps. And sometimes, the doctors and patients may have different perspectives of what was discussed, so it's important to summarize at the end of the meeting what's been heard, what's been understood. And if you find that that becomes a problem for you, or that in general that there's several times or more than once when it seems that you took away one message and then you go back and the doctor says, no, I didn't really mean it that way, or I didn't say it that way, it may actually be necessary or reasonable to suggest maybe somebody else should be in the room as well to help mediate communication or clarify things. And it depends, on where you are being treated and whether or not there are such resources. But I'm just throwing it out as a possibility, again, just to see if there's ways of overcoming some of the normal problems that we know exist. Doctors in general are very keen these days on helping people really understand the prognosis. And the word prognosis, may sound a little confrontational or may not be something that's comfortable, but it's important to understand. And it's important to understand that doctors often want patients to understand the prognosis in order to participate and make decisions that are good for that individual patient. A prognosis is basically a prediction of the course of disease. It talks about the outlook, the chance of surviving, or the chance of deriving a benefit from a certain treatment. Or, looked at differently, it also helps to estimate the chance that a cancer could come back and become more of a chronic problem. Some people prefer to know exactly what the statistics are, others do not. Some people want things framed positively, others don't mind so much. What's important is that, if at all possible, that you sort of understand what's comfortable for you, and then make yourself understood and explain to the clinician, the doctor, the nurse practitioner, how you have found it more helpful to receive such information. Most people want to know their prognosis if it's good, but fewer want to hear the details if it's not so good. And those are the situations, perhaps, which require almost a different level of communication, so that what is actually said is helpful and helps people make the right decisions. doctors may have difficulties communicating, and you perhaps can give me examples of just how often that happens and what kinds of things are miscommunicated or misunderstood. And that may be because some doctors really have difficulties talking about things which are hard. They don't want to, they want patients to like them, they want to be helpful, and they may seem either distant or uncomfortable when the information is not so good, or when people are starting to feel frustrated or express some sort of sadness or some emotion, really, that makes it a little bit more difficult. And some clinicians simply haven't had much training in how to deal with that. So just bring this up here, not as in an apologetic way, but just as a fact, as something that we need to learn to deal with and sometimes figure out how to overcome. This is the last concept here, is that some doctors, especially, and nurses as well, may sort of censor the information. So they may decide, or they may think they're doing the right thing by the patient by perhaps withholding information if they sense somebody doesn't want to know. Or they may say, well, you know, today my patient appears a little bit fragile. She's already teary. I'm not going to go there and discuss, you know, all of the implications of the findings of the scan, or the latest result of a tumor marker or a blood test. So they may find themselves sort of deciding how much information is exchanged. So I'm just pointing this out again because if you're there and you feel that you need to know more, it's impossible. It's possible to overcome this by just making that clear. What I've learned from many years in oncology is that I think what's most important to every person is to be known as such, and not to be known as somebody who carries a disease. So it's important to tell the doctor and the clinician who you are. There's been a historical evolution also of the role of the patient. At the many years and decades ago, patients were supposed to be more quiet, and people talked about victims of cancer and such. If you look at the old literature, that is, it's not something I'm making up. That's how this was often discussed. But now patients really are empowered participants who we expect and encourage to be well informed, to be engaged, to participate in decision making. Having said that, I also recognize that some people want to be very informed, but want to delegate the decision making perhaps to somebody else in their family or to the physician, and that's fine too. There are all sorts of different ways to do this, but it's very important that you feel that your team knows who you are. And sometimes all it takes is just talking for a few minutes about what's important to you, what matters to you, and all of the roles that you have when you're not in your life, what your life is about when you're not there in the medical space, just giving your time as a patient to be treated. So hopefully the relationship between you and your oncologist and your family members can be a satisfying one. I mean, let's be completely honest, nobody wants to have a relationship with an oncologist, but if you have a disease and the oncologist can help, I hope that you find that your relationship is also a source of support and information, and you feel good about that. So communicating in a meaningful and knowing in a meaningful way, and knowing that you have access and that you're known and respected, can actually be quite comforting. So ask yourself what you need from your team. What is most important to you? And remember that what is most important to you may not be the same as for somebody else who's sort of sitting with you in the waiting room. So you need to make your needs understood. You need to sort of prioritize your needs and figure out what's most important. You need to figure out a way of resolving misunderstandings and getting over the fact that things are not going to be perfect. They're not perfect in any relationship. So I think it's important, for instance, that you ask about the things that you want to know a lot about. I had patients who wanted to know in detail everything that could possibly go wrong with a treatment and wanted to take a lot of notes, and others who basically said, look, I'm committing to this treatment. We'll figure it out later. So you need to be straightforward about your needs for information. Perhaps some people want to be sent to sites where there's very detailed, expert-vetted, trustworthy information. And if that's the case, if you constantly feel you need to know more, ask to have more resources. For instance, if you are also consulting somebody who's outside of your doctor's office, or if you are using some acupuncture or herbal medicines, or very much into integrative therapies, but your medical team doesn't know about it, tell them what you're doing, ask for their advice, and try to build a team that works collaboratively. If there is a problem, they should let you know, and if there isn't, then hopefully that you can also talk with them openly about what other sources of treatment or what other sources of support are important to you and are helping you. You need to make sure that your team is a partner in your care, that you feel you're in the loop when decisions are being made, if that's important to you. And it's probably going to feel more satisfying if you feel you're in the loop and you are not passive but active. So again, different people prefer different levels of involvement, have different needs for information. So ask yourself what is best for you. Now, as a physician, I'll tell you sometimes what's hard is when a patient, for instance, says, oh, I'm fine and I really don't want to know more. But let's say her husband says, oh gosh, no, I need to know so much more. I want more information. I want to discuss statistics. So if that's the case in your situation, for instance, if you or your spouse want to know more or less, but you have different needs for information, also figure out a way to have both of your needs met. Perhaps one of you can have a separate conversation or can be turned to a member of the team who can provide more information, and the person who wants to know less is also respected. Handling good news is always easy. Handling bad or disappointing news, not so much. Each one of us needs to find our own way of coping with a shock of unwelcome news. So the things that often help are spending more time with loved ones. I mean, some people feel that, just trying to be positive or upbeat helps. Others may find that this doesn't resonate with them at all. Pursuing passions, pursuing activities that have been put on hold, achieving more insight about life, figuring out what really matters and giving that a priority, putting a plan in effect to deal with a situation. I use the word fight here. Some people feel that it is a battle, and others absolutely hate that term as well, and they view having cancer more as a long-distance effort, or a long-distance run or a marathon. A dear patient of mine once said that she felt that the doctors were sprinters and the patients were there with a marathon mentality, trying to get from 1 mile marker to the other. And the doctors often wanted, something that was faster and more focused on having results. It's possible all of these things just speak to the fact that there may be some common themes, but there may be different language. And I certainly know that the metaphors or the language used by some people may not necessarily resonate with the others. But what I think does work is to just have some organizing principles, having you, if you're the one with the illness, figure really out what works for you and try to make those things clear to your informal caregivers, to your network of family and friends, and also to the members of the professional team, so that you feel respected and understood. And this brings me again to the idea that doctors and patients are always learning from each other, that it's really, there's a mutual learning that goes back and forth, and we need to help each other. I'm not going to get it right from the beginning with everybody. With some people, it may be intuitively easier to help them to understand how they want to communicate, how much they want to be engaged, and for others, it may be a struggle. But the important thing is to move forward and keep doing it. In this case, the patient and the doctor again are sitting there. They both look like they could be discussing a business deal, were it not for the fact that the doctor is wearing a white coat, and he sort of looks at the patient and says, remind me, how long did I tell you you had to live? So this is, of course, a joke, but the point being that we constantly need to be working on the relationship much as we do with other important relationships in our personal lives. And that means that we may not always be of the same point of view. So it's important to understand that there are choices. It is important to figure out if there are differences of opinion, whose opinion is going to prevail, but always to be respectful of the needs, perhaps, and wishes of your family to be involved, and also perhaps if there are differences of opinion, trying very hard to reach a consensus so people will be more at peace with it. And if it comes down to making decisions that mostly are about maintaining quality of life, remember that it's the patient whose life we're talking about. So to have that person, if that is you, to really say what's important, what gives your life most of its good qualities, and what you're prepared to sacrifice, perhaps, and what you're not prepared to sacrifice. If there are some choices to be made about treatments that may be more or less toxic or give more or less time of benefit or likelihood of benefit. Who starts some of these hard conversations? That's always a question that comes up. It could be a patient, it could be the doctor, it could be a family member. Sometimes everybody in the room is equally reluctant to speak openly, and sometimes you have a group of people who are all very engaged and comfortable. So sometimes there are no good moments and no good choices, but you just need to go ahead and do it for the purpose of clarity and to help cope. When there is a lot of uncertainty about what's going to happen, or perhaps if there is a very small expectation of benefit from treatment, and there's a lot of uncertainty because maybe it's a new treatment and we just simply don't yet know even some of the possible toxicities of it, people feel anxious. And the oncologist finds it sometimes very difficult to be very precise, especially when we're talking about new treatments or treatments that are used, after many others have been tried. And so in those moments, it's really challenging. It's hard to be uncertain. It's hard to live with it. So sometimes it helps just to actually have a plan. Whether the plan involves treatment or not is not as important, but just living in that state of uncertainty may be difficult. And if you find yourself there, ask yourself, what is going to help you? What will you regret putting off? What makes the most sense when there is no one straight best way forward? I think it's really important to remember that being ill is difficult, can be isolating, and I am a great proponent of trying to have open communication, because I think that asking for support and being able to receive support can really transform the experience and lower the amount of emotional distress for the patient, but also for her loved ones. So if you're avoiding a conversation, ask yourself why, who are you protecting? And again, my advice for most people is that being able to share things, sometimes it may require a little help in getting to that conversation, but being able to share things and feel supported is beneficial for everybody. As we wind down and close, I want to share this beautiful quote from colleague Bill Bartholomae, who was a physician and an ethicist who was confronted with his own incurable illness and gave a series of beautiful interviews that were captured by Bill Moyers in a series. And one of the things that he said is this, and I'll read it to you. It's been a little over a year now since I discovered I have a fatal disease, and trying to explain to family and friends what having the spirit of time has meant to me, I have found it helpful to characterize it as a gift. To live in the bright light of death is to live a life in which colors and sounds and smells are all the more intense, in which smile and laughs are irresistibly infectious, in which touches and hugs are warm and tender almost beyond belief. I wish that the final chapter in all your stories can have a chapter in which you're given the gift of some time to live with your fatal illness. And so whether the illness is fatal or not is not as important in my message as saying that just having this illness, this unwelcome intruder in your life, may allow you in many ways to make some important choices and decisions. None of us are going to live forever, but it's important to use the time that when we are ill to think about some of the difficulties that may lie ahead, to use the time to prepare those we love for a time perhaps when we're not going to be present, but also to help them feel that they really are helping you or whoever is in this situation at the moment live with it as possible, as well as can be, as well as possible, as long and as well as possible. So my message again is the family and loved ones are ultimately the ones who are going to provide support, but you may find a lot of support with peers by sharing with others who've gone through it. Both giving and receiving peer support is enormously helpful. This can be done in person through groups, but it can also be done through social media and through wonderful organizations such as SHARE. In some cases, religious or spiritual leaders or counselors may help. In some cases, just spending time alone or in nature may help. And sometimes professional help from a psychologist, a social worker, a psychiatrist can also help perhaps get rid of some thoughts that are not allowing us to process all the information. Remember that you're not alone. The members of your professional team want to help. You can find help in your own community and through wonderful organizations such as this. So with that, I'm going to conclude my presentation, and I would open it to questions and comments. Thank you.
Thank you, Dr. Schapira. First question is about framing, the slide that you referenced about framing. So to clarify the benefit of treatment, if a doctor says, for example, that this treatment will reduce your chance of recurrence by 43%, what is a question I should be asking? Should I be asking what is the original chance of recurrence?
Right, so that's a very good question. I think that 43% sounds like a lot, right? So if what we're saying is the treatment is going to almost reduce in half or by 43% your chance of recurrence, the follow-up question should be, and so what is my chance of recurrence? You know, if out of 100 women with my situation, you know, how many will experience a recurrence? And if the answer is, you know, 4 will experience a recurrence, then you might want to say, well, does that mean that 96 will not? And so if 96 will not, then even without treatment, chances are I'm going to be fine. So you can see that all of these things require more information to be exchanged. So hearing about the benefit of treatment presented as a percentage of reduction of risk is great. 43% risk reduction is fabulous, but that's the beginning. Then the next thing is, all right, out of 100 women, how many will experience a recurrence? Okay, if we don't do the treatment, then what are the chances that I will be well in 5 years, and what are the chances that I will have a recurrence in 5 years or 10 years or whatever the interval? See what I'm saying? I think a lot of this depends on, you know, getting a little bit deeper into the statistics, trying to personalize it so you really have a better sense of what you can stand to gain by taking that treatment. Because if cancer treatments were like, you know, eating jelly beans, no problem. We'll all take it even if the amount of benefit is small, but we all know they're not. So before embarking on a treatment, it's really important to understand how much you stand to benefit.
Thank you. So I just want to remind the audience, if you have questions, to go ahead and type them into the question pane. So the next question, do you have any tips about talking with my doctor when we disagree about something?
I think that's a great question. So think about other disagreements you may have had in other relationships with coworkers, with a sister, with a spouse. And talking with your doctor may not be very different from that. I think just respectfully saying, look, we don't see eye to eye on this. This is what is important to me, and what I hear you say is this. can we find a way of talking about what is important to me, and that is X, Y, or Z. So basically laying out the fact that naming there's a disagreement, look, we disagree. And then saying maybe, let me explain my perspective a little bit more. And then say, this is what I'm hearing you say. Can we address, X or Y? So being specific, taking the time, always being respectful, but saying, sending the message, look, I need more from you. This conversation is not satisfying, and this is what I need to know, and I'm not hearing you address it.
Great. Next question. How do I get a doctor to discuss my questions or concerns instead of, quote, brushing them off and rushing out to see the next patient?
My goodness, that's a tough one, and speaks to the fact that the doctors are often rushed, and what ends up not being said or done is maybe actually the most important thing. So I think, again, and this may or may not work, and you may need to be creative about it, but I think the most important thing is to ask yourself how important it is to have your question addressed, to prepare, and before you get started, send an email to somebody on the doctor's team and say, look, I have these two questions that are really important, and I want to make sure that Dr. X has the time to discuss these things with me. Could you let him or her know in advance? So you do what you can basically to say, hey, listen to me, excuse me, I want to discuss these things. And then when you're actually there, in a nice and respectful way, as soon as the doctor comes in the room, say, I really need to discuss a couple things with you. It'll take 8 minutes or 10 minutes or 20 minutes. Can we do this today? Shall we set up a time for a phone call? So don't wait for the last minute. So anticipate how long it's going to take. Try to phrase your questions as clearly as you can. Think about how you can give your doctor sort of a warning that you need more time, and then bring it up as early as you can when you're actually face-to-face.
Great. Next question. I always want to know what the next treatment will be, the next thing we'll try, but my oncologist is very reluctant to answer.
Well, that goes a little bit to some of the slides that when we talked about that, some doctors may be reluctant for different reasons. It could be time constraints. It could be that he or she isn't sure what the next thing is. It could be that it's not his or her style, or they're just, they don't want to burden with you, or they don't have a plan. So you need to figure out a little bit of which one of these you think it is. And again, I think that it's important to try to have a plan and a strategy. So one thing would be to see if there is somebody on the doctor's team, an oncology nurse, a social worker, a nurse practitioner, that you can have a longer conversation and say, look, I'm frustrated. I'm the kind of person who really needs to understand what comes next. And while we're all so engaged in this treatment, I know that this treatment is not going to work forever, so I need to start thinking about what comes next. But I'm frustrated because Dr. Y or Dr. Z, doesn't want to have that conversation. What do you suggest? And see if members of the doctor's team can give you some ideas about how to get that conversation started. The other thing is, again, respectfully say to Dr. Z, look, I trust that you're giving me the best advice, but I need to deal with my anxiety about the fact that this treatment may not work forever or even for a long time, by thinking about what's going to come next. I'd like to have that conversation with you. In fact, I need to have that conversation with you for my own peace of mind, and see what happens. So this is the part where I think you and the doctor need to help each other get to the point of having a conversation that's more satisfying to you. But bear in mind that you may need to guide the doctor there by making statements about your needs, by saying, I'm not questioning, and I know you I'm not holding you to this, and I know that there's a lot about what lies ahead that none of us know, but I need to have a conversation with you to think about what the next 2 or 3 treatments or possible treatments could possibly look like, because I need to know for X, Y, and Z, for peace of mind, to plan my time, to see if I need to get another opinion, to see when I might travel or not. So I think if you're specific and you make it a little easier for the doctor to do this, and perhaps you are a bit more relaxed about it, about the fact that you know it may be a hard conversation, then it's easier for the doctor to understand. And you know, most oncologists do the work they do because they really want to help their patients. So if they can really understand what, and if you can make it more granular for them, this is why I need to know, this is what I want to plan, this is where I'm coming from, I think you'll find that it's more the conversation will be more satisfying and more likely to happen.
So stage 4 patient is asking, when do I start talking to my doctor about dying, and how do I go about doing that?
That's a hard question. After all I've learned in practice and through research and talking to a lot of patients and doctors, I would say the sooner the better, never too soon. And how to do it is maybe a little bit difficult. And again, respectfully, that's why I said sometimes it is the patient who needs to bring it up. So some doctors are very comfortable speaking about it, others are not. But if it's in your mind and you're thinking about it now, then by all means have the conversation. Typically in the world of cancer care, I would say that the oncologists are not all equally comfortable with this conversation. Some may want to just reassure you and say, oh, you know, it's too early, you know, let's not do it. And others may say, sure, what's on your mind? Let's find a time, schedule a time when we're not in a rush so we can sit down for 20 or 30 minutes and really discuss this. Or perhaps if you know your oncologist well, you could even do this over the phone. Another possibility, again, is to ask somebody on the oncologist team, typically a social worker, and say, I would like to speak to my doctor about the fact that I have an incurable illness. I am thinking about death and dying. I need to discuss this in a forthright way and feel that my doctor understands this. How can we do this? And maybe the social worker can be part of that meeting and sort of broker some of the conversation. Another possibility is if you do have access to a palliative care clinician, a nurse practitioner or a physician, to involve them as well. Because palliative medicine clinicians who are increasingly becoming more integrated in the care of patients with stage 4 disease are often expressly trained to be these mediators in communication. They're wonderful in helping patients really understand more about their prognosis, what it means, how to prepare, how to live well. And so they often act as sort of masters of communication and negotiation. So they play sometimes almost a diplomatic role, the linking patient and the things the patient wants to talk about with the oncologist, who sometimes is more focused on disease, treatment of disease, and moving from one treatment to the other.
So that's a great segue into the next question, which is, how can one deal with an oncologist who is resistant to the idea of palliative care? And I know that this comes up quite a bit because we had a situation here where a stage 4 metastatic breast cancer patient asked a doctor about palliative care, and his reply was, you're not ready yet. And she said, well, I read a bunch of studies that said that there could be better outcomes with palliative care, and the response was the same.
So I am with you on that one, and I would say you talk to the doctor, you talk evidence to the doctor. There are certainly studies that support the early integration of palliative care and show that they improve outcomes, including the very hard outcomes that oncologists are, hold dear, which is to live longer, not just to live better, but live longer. So I think in that case, I would suggest that if palliative care is available in that center, that say to the patient that she should insist, or that somebody else in the team should make the referral, or she should self-refer. So once you do that, then you see what happens. And if the oncologist can't take it, well then, that may be a moment of crisis in the relationship. But the person who asked this question is absolutely right. There's plenty of good evidence that early integration of palliative care improves the quality of life, the lived experience, and sometimes even prolonged survival. So she has absolutely every reason to insist and demand. I'm always one for trying to be, conciliatory and to negotiate these things. But if that's not possible, then self-referring, finding a palliative care clinician, and setting up a consult is probably the right way to go.
And who's the best person to help with end-of-life issues for myself and my caregiver?
It depends on the folks who are available to you, wherever you're receiving care. Palliative teams, palliative care clinicians are trained to do that. So they are trained to play in a way, sort of a supportive, sometimes accompanying role throughout all phases of the cancer journey. But they often are the primary clinicians involved in the last phase of life. So palliative care clinicians often manage the last 2 months of life. They also oversee care that's delivered with in conjunction with hospices, or they assume care during those final months. There are some oncologists who are very comfortable and great at it, and so I'm reluctant to give just one answer, because in some cases oncologists are comfortable, familiar, experienced, and are great at it, and it may be more comfortable with for the patient to just continue with the same oncologist and the same team. But in increasingly more situations, palliative medicine clinicians, nurse practitioners, and physicians are the ones who handle the symptoms, and as less anti-cancer treatment is taking place, they become sort of the primary clinicians involved in managing symptoms and addressing emotional and spiritual concerns, and providing help not just for patient but also for family caregivers.
So thank you. That was the last question that we have time for. I'd like to thank Dr. Schapira for an informative program, and thank you to everyone for participating. If you don't mind, please take a moment to fill out the survey at the end of the webinar. It may take a minute to download, but it provides us with information to help build better programs for you. Thanks so much, Dr. Schapira. Really appreciate it.
You're welcome.
Thanks, everyone.